Unless you've been hiding under a rock, you've definitely noticed the crazy amount of attention cycle charting, menstrual cycle health, and fertility awareness is getting lately. More and more women are discovering it, starting to chart, and they need your support. As fertility awareness becomes more mainstream, you owe it to your clients to specialize. If you have a women's health practice and you don't yet have the skills to provide complex menstrual cycle chart analysis, you're missing out on a huge opportunity. The next round of FAMM starts in July, and this is the last time we're offering it in 2025. If you are waiting for the perfect time to join, it's now. Head over to fertilityfriday.com/FAMWL to join the waiting list today. That's fertilityfriday.com/FAMMWL, and you'll be the first to know when registration opens up again. Again, that's fertilityfriday.com/FAMMWL. This is the Fertility Friday podcast, episode number 573. In today's episode, we are touching on a really interesting topic. I'm going through a paper that is looking at male contraception and really examining the question of why don't we have a hormonal contraceptive for men yet? You know, women have had these hormonal contraceptive options for over 60 years. What's the holdup? Is there a reason that we are not seeing more medical advances in the field of male contraception? I think there's several reasons for this, which we're going to talk a little bit more about today. And I think it's going to be really interesting because, of course, I feel like there's a double standard here. And I do feel like they're a lot more concerned about the side effects when it comes to men versus the level of concern or lack thereof that they've had for women using similar formulations. But that and more coming up. So let's go ahead and get into today's episode. So as we know, the current options for contraceptives for men are limited. There are condoms, withdrawal, and sterilization. You know, that's basically it. So in terms of the question of why we haven't seen advances in this area of hormonal contraceptives for men, I think that there's a few reasons. One, I think that because the market for female contraceptives is so big, it is a multi-billion-dollar per year industry, well over $20 or $30 billion. And they estimate that over 100 million women worldwide use contraceptives. And medical professionals are instructed to put women on birth control as soon as possible, not only for contraceptive reasons, but there's a long list of other reasons. I mean, anything really, any issue you have with your period, any issue you have with your cycle, any issue you have even with acne or with moods or whatever, pill. And then when you are ready to have a baby, they say, okay, come off and have a baby. But as soon as you're done having a baby, they want you to go back on. And ultimately, they want you to be on the pill until you go through menopause. And then when you go on menopause, they want you on HRT. So at the end of the day, this is a multi-billion-dollar industry. And I do believe that part of the reason we haven't seen that development in male contraception is because they're afraid that it would dip into their kind of money pot or honey pot or whatever, if you will. So I think that's one issue. The other issue is, you know, I do get this sense after reading through many papers of male contraceptive trials, including this paper, there are certain side effects that do crop up. But what I have observed is that when these side effects come up in men, there does seem to be more interest. There does seem to be more concern. And so, for example, one of the challenges with creating a male contraceptive is that in order to suppress sperm production, they need to find a way to suppress testosterone because testosterone is highly correlated with sperm production. So in order to get a man to stop making sperm, they need to suppress this testosterone. But if you suppress testosterone to a certain level, then you run the risk of interfering with his sexual function, interfering with his ability to have and maintain an erection and, you know, achieve sexual satisfaction. So then you have this magic window of how much you can suppress the testosterone while still maintaining his sexual function. And so when you read the studies and you see that, you know, this is one of the things that they're concerned about when there are issues with sexual function or with mood, you know, changes or There was one study that reported like aggression increased, aggressive tendencies increased, and different mood changes occurred. There does seem to be more of a kind of immediate concern around these things. Whereas with women, I don't feel that there's that same level of concern. If you look into pill research, hormonal contraceptive research, there is a significant issue with how the pill affects sexual function. There are studies that show that the pill significantly decreases testosterone levels in women. And many women experience a thinning of the vulvar tissues. So those are the tissues around the vaginal opening, including the clitoris. So numerous studies have shown that, this significant drop of testosterone has a negative impact on female sexual function. And some studies even show that women have some women report a more difficult time achieving orgasm, having less arousal, having less sexual interest, and just, the list kind of goes on, but that's not really considered to be a problem. Like it's not like women complaining about sexual changes has ever stopped the pill formulations from coming out in any way. But yet, when these types of issues come up in the research around male contraception, it seems like they're a lot more concerned about it. And they're certainly still tweaking the formulation to try to minimize that as much as possible. So that's definitely one observation that I've made. And you can think about that what you will. So as I mentioned, one of the challenges then is finding the right amount of dose in terms of, the hormones that they're trying to administer. Another issue is how they administer it. So if they administer it transdermally, so on the skin, if they administer it orally versus if they give an injection or, figure out some kind of slow release formulation. All of these are important factors because for men doing an oral dosing, their bodies are metabolizing it very quickly. So therefore the effect may not be consistent. Whereas perhaps in women, they found a way to kind of organize that so that it's not as much of a problem. So these are some of the challenges that the researchers talk about in studies. And one thing I think I should mention too is that by me going through this information, by no means am I saying that I actually think it's a good idea for men to have hormonal contraceptions. After spending so much time talking about the pill and all the potential negative effects that it has on women, going through research, studies, talking with thousands of women over the years, interviewing many women on this podcast who share their experiences, it's clear that adding in hormones to the woman and changes her body in ways that we wouldn't necessarily anticipate. So given that, I'm not necessarily saying that. I think it's a fantastic idea for us to introduce this can of worms with men as well. I think that it is worthwhile, though, to have this conversation, to look at the research, to look at the implications, and then to really ask, is this a good idea? But at the end of the day, women have been subjected to this hormonal contraceptive situation for so long, almost 70 years, right? Like it's about 65 years now because the first pill came out in 1960. So why is there this double standard? Why is it okay for women but not men? So I'll just kind of leave that right there as well. So when they're looking to formulate a contraceptive option for men, what they're trying to do is they're trying to administer these hormones in such a way that it is going to severely restrict his sperm production or cause there to be no sperm at all. And so the way that they measure this can be slightly different depending on the study. But they are typically looking to get the sperm concentration below 3 million sperm per milliliter or below 1 million sperm per milliliter. And to put it into perspective, according to the World Health Organization, a sperm concentration of 15 million per milliliter or below would be a problem. And so having a hormonal situation that would reduce a man's sperm count to barely anything, so barely 1 million sperm per milliliter or less, would then make it theoretically an effective contraceptive method. So there was one study that they went over that was conducted by the World Health Organization. And what was interesting about that study is that depending on the ethnicity of the men, there was a difference in terms of how effective the drug was. So based on what the study said, they said these trials indicated that nearly 60% of non-Chinese and over 90% of Chinese men attained azoospermia, meaning 60% of non-Chinese men and over 90% of Chinese men they had no sperm based on the administration of testosterone that they were given. I thought that that was interesting. So I think it kind of speaks to the fact that male bodies aren't all the same. And so even if you give the same hormone to a group of men, some could respond slightly differently to others. So, and then they said, while the remainder were severely oligospermic. So there were some who had no sperm, and then the rest had very little. So under 3 million sperm per milliliter. And the pregnancy rate was really low. So in many ways, this trial was quite effective in that they were, even though there were these differences ethnically, they still, like the majority of the men still had like just barely any sperm at all. And so technically it actually worked. So when you read stuff like this, the question is, well, then why didn't it go forward? And as you read through these different trials, you see that although it worked to suppress the sperm, there were other issues. There were issues with libido. There were issues with depression. There were issues with mood changes. There were issues with, so they hadn't quite worked it all out. And even though a lot of these issues are very similar to the issues women still struggle with contraceptives, it's enough that they haven't really moved forward and actually released anything. So that's one of the things I found. So if we go through and look at some of the other studies that they examined here, there were a few other trials that they detailed in the study where men were given a monthly injection of testosterone. And one of the interesting things, just as you read through the research, is that it's not an instant thing. And if you think about how sperm is made, so the research tells us it takes an average of about 74 days. You can think 3 months or so. So, if we look at the assembly line that's going on in the testes, it does take about 3 months for the sperm to be produced. So that could be part of the reason why. But when these men are given the testosterone, they are not instantly infertile. So it typically is taking about 3 months or so before they're actually doing the semen analysis and showing the sperm levels below like 3 million sperm per milliliter or 1 million sperm per milliliter, depending on their specific criteria. So I think that's an interesting piece of it as well, because with female contraception, it's typically taking effect quite quickly, but with male contraception, it's taking a little bit longer. And also the efficacy rates vary. So some of the studies are showing a really high efficacy rate where, you only have maybe 1% or less of the participants who might have had who may have conceived, similar to the standard kind of contraceptive rates we're used to with the birth control pill or other formulations. But some of these studies were showing a failure rate of, 6%, 5%. So again, they're still working out the kinks. So, those two factors could also be part of the reason why we haven't seen a rollout, because it's not showing, although it does show high efficacy, it's not showing as consistently high. It also takes a little bit of time for it to kick in. And I also noticed a bit of an interesting trend where they would always list the side effects. So I think this is something, although I'm saying that they are certainly more concerned about the side effects for men, they still downplay to some extent, but some of the common side effects include things that you would think, whether it's acne, oiliness of the skin, weight gain. One of the studies showed decrease in the size of testicles, changes in sexual function and mood. So there, the researchers will use the terms like these were relatively mild and they were reversible and blah, blah, blah. So the same kind of stuff that we're used to hearing for female contraception. But the difference is that even though these studies are taking place, they're showing relatively high efficacy and they're saying that the side effects are fairly minimal, we still haven't seen a formulation come out. So that's one thing where it's like, it all looks very similar to the female contraception, except we haven't seen anything roll out. Some of the new formulations that they're trying are combining testosterone with progestin. So they're doing a synthetic progestin, synthetic T. And the thought behind that is that if they use the progestin to suppress sperm production, so to interfere with the hypothalamic pituitary gonadal axis, the conversation that's happening within the male body, then they can add a little bit of testosterone to kind of make up for the fact that so much testosterone has been reduced and potentially alleviate some of those sexual side effects. So like I said at the beginning, one of the challenges is in order to stop the sperm production, we have to lower the testosterone. But when you lower the testosterone, it can have these detrimental effects on male sexuality. So they have to find a way to suppress the sperm, but in this case, potentially give a little bit back. So add in some synthetic testosterone so that he can still have the sexual function without the sperm production. So again, these are some of the challenges that they're outlining in this paper of why we still don't have a formulation. Save the date, ladies. The next round of FAMM starts in July. And this is the last time that we're opening our doors in 2025. And if you're thinking about joining us, now is the perfect time. And here's why. We're all busy. None of our practitioners magically had time. Their schedules didn't just clear like the Red Sea parting or anything like that. Their prior appointments or commitments, they didn't just disappear, but they knew that FAMM's unique training model was exactly what they needed in their business, and they made it happen.
Even just before getting into the program, I know when we were having conversation about whether or not if it was the right time, just with me having my daughter and trying to start my business, but also still working another full-time job and, doing all these things. Even though it felt like it wasn't the right time, it was the perfect time, especially me being postpartum and preparing again for my next pregnancy. It was the perfect time for me to learn how to track and chart my own cycles and being able to incorporate this now with my offering in my practice. If there's someone listening to this and they're like, oh, I think I want to do it, but now is not the right time, it's the right time. Take this as your sign.
That was Rhoda Chi, registered dietitian nutritionist and one of our FAMM practitioners in training, who found a way to make it happen in the midst of a very full life. Our next class starts in July, and this will be the last time we're offering FAMM in 2025. Head over to fertilityfriday.com/FAMMWL. That's fertilityfriday.com/FAMMWL to join the waiting list today, and you'll be the first to know when registration opens up again. That's fertilityfriday.com/FAMMWL. Now, one study that I've spoken about before, I wrote about it in the Fifth Vital Sign. This study was of 320 healthy fertile men. They administered testosterone by injection. And this was the study, if you haven't heard of it, that was stopped midway. So as they were going into the study, these men were being given the testosterone, and the testosterone was successful in suppressing sperm production. So there was a high rate of efficacy, and the pregnancy rate in the study was only 1.57%. So it was very high efficacy, equivalent to the kind of contraceptive methods that we are comfortable with. But the study was terminated early because a safety committee jumped in and said, wait a minute, the side effects these men are experiencing are too high. So some of these men were experiencing mood changes. There was depression, there was pain at the injection site, increased libido. So there were certain things. And during the study, there was one death by suicide that occurred some point after they had been administering the testosterone. But what they said in the study was that they don't think it's related, but they still called off the study. So, I mean, that's an interesting study. If you've never heard of it before, it's super agitating because when you actually read the study, super agitating because I feel like women have been dealing with very similar side effects, for 65 years, and no one ever called that study off. That's still ongoing. But as soon as you have a few men that are experiencing a negative side effect, they just jump in. So by no means do I think men should have to suffer. I don't think anyone should have to suffer. But my question is, why are we so much more concerned about the men at the end of the day? In addition to the side effects that I have mentioned already, other studies have found some concerning side effects in men specifically. Testosterone therapy may be associated with increases in cardiovascular disease risk, including myocardial infarction and stroke. And again, some of these risk factors, similar to the increase in blood clots and stroke in women, but in this realm of study, in the realm of male contraception, it is enough to get them to stop until they're able to mitigate that risk. So the difference is that although with regards to female contraception, even though there are similar risk factors, that never stopped them from putting it out there. They just put a warning label on it. But for the male contraceptive industry, this increased risk of, cardiovascular issues and heart attack and stroke is enough to make the researchers and the industry pause until they can improve the formulation. So they're actually looking for ways to suppress the sperm production that are not going to interfere with the hormone situation and are not going to cause the same kind of sexual dysfunction issues and potentially lower the cardiovascular issues. And this is one of the big reasons why there haven't been the same level of advancement with male contraception. They're just way more concerned about this. So again, it's really fascinating. One other factor that is not, they talk about it, but I would say that they're not talking about it. They don't seem to be as concerned about it. But I do think that this is an issue, but they don't seem to be as concerned about it. In this particular paper, I just don't feel like it got that much attention. But there is a concern. So I have a significant concern with male hormonal contraception. And what it is how long it takes for men to recover normal sperm production. That's a huge, huge problem. So there are a number of studies that have shown that when men are given exogenous testosterone, so even if it's not contraception, so even if a man has low testosterone and his doctor gives him testosterone replacement, or if a man is taking steroids, so when men take testosterone, it is known to significantly lower their sperm production. And this is one of the reasons why it would make an optimal, or not necessarily optimal, but this is one of the reasons that it makes an effective contraception. And so you give a man testosterone, it significantly impairs his sperm production. But then when you stop giving him the testosterone, it can take anywhere from 1 to 2 years or more for his sperm production to fully restore and normalize. 1 to 2 years. So this is something I found interesting because in this paper, they said recovery to greater than 20 million sperm per milliliter occurred in nearly all participants by 12 months. So they just kind of almost everybody at the end of the 12-month period, recovered. But is 20 million per milliliter optimal? I mean, no, it's not. The research shows that optimal sperm production is somewhere around 50 million sperm per milliliter. And it could take a year for it to restore. And other studies, when we're looking at it, show that it can take up to 2 years. So even when they look at it, it says the probability of recovery to 20 million within 12 months was 90 and 100% within 24 months. So they're saying 90% of men had sperm concentrations of 20 million sperm per milliliter at the 12-month mark, and all of them did within 24 months in one of the studies that they mentioned. But I would say that's a pretty significant issue that they're kind of skirting. So in terms of, the big reasons, I think, if you kind of put it all together, why we don't have a male hormonal contraceptive option, the industry they don't want to kind of mess with their cash cow. So I do think that plays a role. They haven't found a formulation that is free of these side effects, and they've had challenges. So they're really working on creating some sort of formulation that can suppress the sperm without having this effect on the sexual function and also potentially reducing any hormonal interactions, so that, because that's why they're having those issues. There's issues with some of those side effects. The researchers seem to be super concerned about those. I don't know that they're so concerned about the recovery of sperm, but I do think that would become a big factor if it doesn't, if not all men are back to normal within a year or two. That could cause significant issues, especially for couples that are trying to get pregnant. And I've seen this on the flip side with fertility clients whose partners were they didn't know that if they were taking steroids, maybe they work out and they've got some, gym goals or whatever, but maybe or even some cases where they're being given testosterone because maybe their testosterone was low. A lot of men who are taking testosterone for one reason or another have no idea that it causes them to have basically virtually like low to no sperm count. And certainly they're not aware of how long it would take them to recover normal sperm production after that. So I would say those are some huge issues. So according to this study, though, there's some promising new research. They have some promising formulations. And it's kind of like any minute now, we're going to have it, any minute now. And they're doing a little bit of damage control. Like most of the side effects are pretty minimal and the efficacy is really high. But when you go through everything in its entirety, you can see that there are still some major concerns that they have. And even though all these years they've been doing all these trials since the 70s, showing that when you have these hormonal contraceptive options for men, if we're injecting them, if they're doing this and that they are consistently, like pretty reliably lowering the testosterone levels. They could theoretically make it into an effective formulation. They just keep kicking down the can because they're just super concerned about the side effects. And they should be concerned about the side effects, but I feel like they should also be concerned about the side effects for women, and they're not. So what do you think? I mean, I'd be really curious to know what you think about this state of affairs. Do you think they should go ahead and push out a contraceptive option for men? I mean, frankly, I think that it would cause a lot of chaos. I think that with everything we've talked about, these men would certainly be at a greater risk of various different side effects because it is messing with their hormones. Definitely could have this negative effect on sexuality, sexual function. It could definitely change moods and all of that kind of stuff. And certainly those are some really big concerns. There's also the cardiovascular risk and, the risk of heart attack, stroke, all of that kind of stuff that could be increased, which is, I can't get behind all of that because I'm not really behind it as far as the women are concerned. But again, because I work with a lot of, fertility clients and we work with a lot of practitioners who are looking to support fertility clients as well, introducing something like this could have a really significant effect on fertility, given the duration of time it can take for men to recover their normal sperm production. So I do think there's some significant red flags here. I'm not necessarily of the opinion that I think it's a great idea to start messing around with men's hormones too. But I do think it's really interesting. I feel like they've just taken a lot more care and a lot more time. I mean, they've been at this for decades. I couldn't believe it when I saw that they've been doing studies since the 70s. And because of these issues, they have stopped. Whereas the studies on women's hormonal contraceptive options show very similar, if not the exact same, identical side effects. Yet these drugs are out and we're just, sitting ducks. So if you're anything like me, I suppose we'll just kind of wait patiently to see what happens, to see if they really do come out with a male contraceptive and to see how they're going to manage this side effect conversation. I do think that if they do decide to come out with something, the side effect conversation is going to be very, very different. I just don't think that they're going to get away with giving men a significantly increased cardiovascular risk and having a really negative impact on their sexual. I just don't think they're going to get away with it the way that they have with female contraception. I feel like it's just going to be a totally different situation. And I think that that's the reason why they haven't done it. I think that the reason they haven't done it is because they know that they can't get away with it to the same degree that they have been for the last 65 years with women. So we will see. If you found today's episode interesting, if you're wanting to grab the study and look more deeply into some of the reviews that I was talking about, because they looked at multiple trials that have been done throughout the years and they kind of, summarized everything, then feel free to head over to fertilityfriday.com/573. So that's fertilityfriday.com/573. If you can think of someone who would benefit from hearing today's episode, feel free to share. And if you've been enjoying our FAMM research series, head over to fertilityfriday.com/research for a full list of our past episodes in this series. So with that said, I hope you have a wonderful weekend, whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting. If you enjoyed today's episode, you're going to love our top resource for women's health professionals, How to Interpret Virtually Any Chart Your Client Throws at You. Our newest ebook breaks down complex chart interpretation into an easy step-by-step process. Head over to fertilityfriday.com/chart to snag your complimentary copy today. That's fertilityfriday.com/chart.